Right. I guess we can go ahead and get started. I'm Stacy Weeks. I'm the administrator for the Division of Healthcare Financing and Policy. Again, this meeting is being recorded. So, and at the end, we will open it up for questions and try our best to answer as many questions as we can today. We have quite a full deck here for all of us to review. But let's go ahead and get started. Next slide, Melinda. All right, so today we want to do a little welcome first. We're trying to do something a little different where we have a conversation early on about where things are in our implementation process. Give us an opportunity to talk to you all kind of together. We often sometimes get one-off requests, and we thought this would be a nice way where we can get the information out on how we're implementing legislation from session, and also give you all an update on where we are generally with some big projects. As you can see here, we'll do a quick overview of where we are at the division, some of our major projects that we're working on, that are in some ways separate from legislation that passed, and some of them are connected. And then we have just general bill updates at the end. And we have a lot of folks from our team on today to walk through these bills and where we are in implementation. Next slide. All right. So I might, if it's okay, just have the deputies and our clinicians, our senior clinicians come on and introduce themselves real quick. I don't think we have time for the whole team today in the interest of time. Melinda, did you want to start real quick and say hi?
Sure. Thanks, Stacy. Hi, everybody. My name is Melinda Southard, and I'm the Deputy Administrator for Community Supports and Engagement. So I oversee long-term services and supports, the district offices, the Community and Provider Engagement Unit, and our new federal waiver team. Thanks.
Hi, I'm Sandy Rublid. I'm another deputy administrator with the division. I oversee our compliance, IT, HR, and SURF and program integrity.
Thanks, Sandy. Keith, did you want to go next?
Sure. Good afternoon. My name is Dr. Keith Benson, and I am the State Dental Officer here at Medicaid. I'm overseeing the ID waiver program, the 1115 waiver, and legislation that we'll talk about. Nice to meet you.
Dr. Clemens, are you on today? I'm having a hard time seeing who's all on here.
Hi, I'm on. This is Dr. Clemens. I'm the new medical director for Medicaid and currently overseeing the pharmacy and DME, and also serve as clinical leadership, providing advice to this division as well as to multiple divisions in the Department of Health and Human Services. Thank you.
Thanks, Dr. Clemens. And so Teresa Carson is our other deputy. She is out. Today is her birthday. She's over our managed care program, and she's over benefits and delivery systems together. And then we also, Lynette Aaron is also out, and she's over our fiscal team right now, as well as Ashwini Prasad. And they both are one of them's on another call and the other is out today. So but we'll go ahead and get started. The meeting purpose, just so everyone has the sense, like I mentioned earlier, we're trying something new and would love your feedback afterwards about how it went, and just trying to get the information out about how we're implementing legislation and where we are on major projects at the division. Next slide. So right now, this is the our executive leadership team at the division. Everyone that kind of came on camera, you already met. As you can see, we are in the process of looking for a fiscal or finance deputy, as well as a pharmacy director. We're hopeful we might have someone soon for that position because we've just finished interviews. And then division compliance officer will also be hiring soon. That position we also got this session, that position as well as our pharmacy director from the legislative session. Next slide. Whoops. A little fast there, Melinda. Thanks. So the division mission, I think you all are well aware of this mission, but it's really to promote a healthier Nevada through Medicaid and all the programs that we oversee, the checkup program as well. We purchase and provide quality healthcare services at the division, as well as promote equal access to healthcare and affordable costs to taxpayers in Nevada. We also look at controlling the cost of healthcare in our program, ensuring it's sustainable And we work toward reviewing Medicaid and other state healthcare programs to maximize federal revenue to the state. Next slide. I think you guys are well aware of these stats, but just in case, it's always good to see, and some of you may have not seen these before, but just want to give a sense of where our program is right now and how big it has gotten. Our next biennium, the budget is projected to be over 16 billion for the biennium. We cover 1 and 2 births in Nevada, and about 75, 78%, depending on the month this year. Most recipients are served by managed care, and we'll talk a little bit in a minute that program will be expanding, I think, as many of you know. And once it expands, it'll be closer to 85% of the program. 44% of the recipients are children, so that's 1 in 3 children in Nevada are served by Medicaid. We have 10% of our population is dually eligible, so it's about 91,000 individuals. 80% of our population lives in Clark County, and 62% of the costs of nursing facility bed stays in Nevada are paid by Medicaid. And 62% of adults enrolled in Medicaid are employed, and 64% of Nevadans are people of color. Next slide. This is just a quick high-level overview of all that's happened this session and the impact on our program. So there were 56 bills that passed that have an impact and implementation that we're working on right now. 2 of them require 2 new state regulations. So I'll be working with the department and the director's office on that. And then we have 24 other major projects. Some are related to federal requirements that have come down from CMS on the state, and some are related to previous legislation that we're still implementing. For example, different waiver programs and those types of projects. And then we have 46 of the implementation activities for this last session that impacts our MMIS system for the program, and 22 of these bills require state plan. We'll have 22 state plan amendments to implement them, as well as policy updates, 21 policy updates. Next slide. So right now, just to give you guys a sense of what we're aiming to do, we're trying our best to really make sure the work is focused on in these 4 key areas. And it's really, putting the people we serve first, right? What is the consumer experience? So a lot of things that we're doing at the division is looking at what is it like for someone trying to access these services. So we might be looking at policy updates, different changes in how we do things to really make sure that the person that's supposed to be served is getting the access to services that are available, as well as thinking about how our providers experience the program and where we can supporting providers. So really increasing access to care. One of those things is we've developed a new access unit, which will be implementing some of the new requirements around access that are coming down from the federal government soon, but also just looking generally at some of the access issues in our program and ways that we can improve access and bringing those policy ideas to the forefront so we can work with stakeholders on them. The other piece that we're trying our best to do as we all struggle with workforce shortage is efficiencies in our workplace. We are right now hiring, and we'll be hiring more in October, and a lot of divisions and departments will be as well from session. We're also looking at process improvement internally, like I mentioned, as well as automating and modernizing the technology we have to do the business faster and easier and with less manpower. We're also looking at smart fiscal stewardship and making sure that we spend within our authority. Often I know folks want us to give a lot of rate increases or other things, but just trying to do our best to maintain our budget so we have a sustainable program for the people we serve. One thing to remember is that we are losing that enhanced federal funding that we had during the public health emergency for COVID-19. That ends fully at the end of this year, and we'll be going back to the regular FMAP. And so, that does impact our budget. And so just something to, I know during session, it was, we reflected that in our base, but it's something to think about. And then also just remembering, if we're not sustainable, versus cuts, right? So it's always that balance of making sure that we don't spend too much, that we're in a position of having to cut our program in the future. And again, looking to maximize federal funding where we can. There are lots of different ways to do that. And we're always open to ideas if stakeholders have things they want to bring forward on that. And this is something Melinda's going to talk a lot about, is this community and provider partnership. Something we're trying to really elevate in the program is bring forward this new team and unit to really look at partnering with community organizations and recipients as well as providers and working on issues together. And then and also the purpose of this is to provide greater transparency into the division and some direction of where people should go when they get stuck, right? And then, instead of just informing, it's a little bit of that, not just giving us feedback, but informing the policy as we develop it. So we're doing our best to try to bring that forward to stakeholders. Next slide. All right, Melinda, it's yours.
All right. Thank you, Stacy. Now I'd like to take a moment to introduce everyone to a new unit within Nevada Medicaid, the Community and Provider Engagement Unit. So the reason this unit was developed and the vision behind this unit is really to elevate stakeholder engagement within the division and give better opportunities to foster more meaningful partnerships between the division and its stakeholders, which are all of you. This unit is meant to promote more effective communication and collaboration with our community and healthcare provider partners. A few key staff members I wanted to highlight within this unit include our division tribal and community liaison, Ms. Monica Schiffer, and our school health liaison, Ms. Rosanna Dagdon. Monica and Rosanna will be able to introduce themselves to you all in the next slide, but I wanted to quickly note that the division is really trying to elevate this collaborative work to help break down any unnecessary barriers when it comes to providers billing Medicaid for services rendered to our recipients. This new unit will also be responsible for managing the division's large stakeholder committees, such as the Medical Care Advisory Committee, or MCAC, the Medicaid Reinvestment Advisory Committee, or MRAC, and so on. This unit will be working closely with the chairs of the committees to develop meeting schedules, logistics, and ensuring that during these meetings, more two-way conversations with Medicaid that are meaningful and to help drive action in a positive direction. Our medical director, Dr. Rashonda Clemens, and our dental health officer, Dr. Keith Benson, have both graciously agreed to serve in an advisory role to this new unit in their important stakeholder work. And then lastly, this new unit is intended to serve as a point of contact and resource for you all in how to best engage with Nevada Medicaid. So here I provided an overview of the structure of the new unit for your reference. As you can see, our two leadership positions in this unit are currently vacant. We are conducting interviews now, though, for the unit leader, the external stakeholder chief, and hope to have someone onboarded in early October. Additionally, we are recruiting for another chief position, a waiver and stakeholder director, who will oversee both the federal waiver team and this new unit. We hope to have that position filled by the middle to end of October. Reporting to the unit chief will be the school services specialist, the tribal and community liaison, and eventually a healthcare coordinator to assist in the care coordination piece of the 1115 waiver for the incarcerated population that's associated with Assembly Bill 389 that was passed this session. Now I'd like to turn it over first to Rosanna and then to Monica to please introduce yourselves and provide a quick overview of what you do in interacting with stakeholders. Rosanna or Monica?
Sorry, I was waiting for Rosanna, but I will go ahead and go while we wait for her. Good afternoon, everybody. My name is Monica Schiffer. I have worked with the Division of Healthcare Finance and Policy since I believe about 2015. Originally, I was in the hearings unit, and now I am in the new Community Supports and Engagement unit. I worked in conjunction with a previous tribal liaison for the last 2 years and am happy to say that I am excited to be part of this new unit. I look forward to working with everybody. I would like to be available for questions, for comments, to help direct anybody. And I am just looking forward to working with all of you folks. And please feel free to reach out if I can be of any assistance. Thank you, Melinda.
Thank you, Monica. And Rosanna, are you available? Okay, no worries. We will move forward. Thank you so much. Okay. All right, so to wrap things up about this new unit, we offer a few tips for when it might be a good time to reach out to someone in our community and provider engagement unit so that we can problem solve, help to get you to the right person who knows the answer, and hopefully mitigate the challenges or issues that you're having wherever we can. I'm not going to read each one of these to you, but you can see that basically the email address that's listed below, or community and provider at dhcfp.nv.gov, is intended to be our stakeholder help button. So this is meant to help problem solve, or if you have ideas where you think that we could do things better, we'd of course love to hear those too. So now I'd like to hand it back over to our administrator to introduce you to some major project updates in the division.
Thanks, Melinda. So like I mentioned earlier, we wanted to give a quick overview on some of the big projects that we're working on that sometimes are a little bit separate from what passed during session. They may be impacted by them, and just generally because they are impacting our program and a lot of the work that we're doing. So I will kick it over to the folks that are doing this big work. Next slide. And this first one is, I think, Vanessa on our team, or Sandy. I'm not sure which one wants to take it. Vanessa, thank you.
I'll take it, Stacy. Thank you. Good afternoon. My name is Vanessa Ramey. I'm the project manager overseeing the COVID-19 Public Health Emergency Unwinding Project. For those who are not aware, the Medicaid continuous enrollment was implemented in response to the COVID-19 public health emergency, which has ended. As of March 31st, 2023, under the Consolidated Appropriations Act of 2023, states were tasked to unwind the continuous eligibility and return to normal operations. The unwinding efforts primarily refers to the process of reviewing and redetermining eligibility of everyone enrolled in Medicaid after the end of the continuous enrollment condition. Nevada began unwinding on April 1st for June renewals. June was the first time disenrollment occurred since the pandemic. Nevada recently responded to a federal compliance issue with its ex parte process, which required certain actions to mitigate those impacted. Ex parte is an automated process which matches up to 5 data sources. Individuals renewed via ex parte do not require a caseworker or member to take any action, and Medicaid is automatically renewed for 12 months. As a mitigation, Nevada has paused procedural terminations for October to December of 2023 until ex parte is corrected. In addition, as of last week, September 14th, we reinstated approximately 114,000 individuals who were procedurally terminated between June and August. Individuals reinstated have been notified by mail, and a text message will be sent out starting today, and the completion of those texts will be completed by tomorrow. Nevada Medicaid encourages individuals to contact their Medicaid provider to address any billing and payment concerns and to secure potential reimbursement of Medicaid covered services during the lapse in coverage. Our unwinding timeline has been extended. Now is slated to be completed tentatively by the end of December of 2024, which was originally planned to end of May of 2024. Be sure to visit our Unwinding COVID-19 webpage for the latest information. For members affected, we encourage them to check their mail. And if they're interested in more information or resources, they should visit our member webpage. Both of these websites are listed at the bottom of this slide. We also highly encourage Medicaid members to update their contact information if they have recently moved. That concludes my update. Thank you so much for your time. Now I'm going to hand it over to Cynthia Leach, who will talk to you a little bit about centralized credentialing. Thank you.
Thanks, Vanessa. Good afternoon. My name is Cynthia Leach. I'm the Program Integrity Chief for Nevada Medicaid, and we'll be providing an update on the centralized credentialing project. Provider credentialing is the process of ensuring medical providers have proper qualifications. A credentialing organization makes sure there are no past reported issues that suggest providers are incapable of competently treating patients. The credentialing process is in addition to the existing screening and enrollment process currently performed by the division's fiscal agent. So why are we moving to a centralized credentialing process for Nevada Medicaid? Centralized credentialing provides multiple benefits. It creates a single point of entry for credentialing, so essentially a one-stop shop. Currently, providers wishing to join the network of one of Nevada Medicaid's managed care entities must submit credentialing documentation to each plan, creating administrative burden and resulting in multiple processing times and potentially different decisions. The selected credentialing vendor will be required to adhere to the National Committee for Quality Assurance, or NCQA, guidelines. Credentialing provides a robust verification and validation process that expands pre-enrollment reviews to include assessment of providers' qualifications to perform services. For example, credentialing looks at education, training, liability, record, and practice history. The process will maintain the managed care plan's ability to make network decisions and maintain NCQA accreditation, yet credentialing of providers must still be honored. Centralized credentialing provides visibility into the process for providers with one timeline and a consistent procedure. The division is currently finalizing its procurement for a qualified credentials verification organization, or CVO, vendor to establish and provide centralized credentialing and recredentialing services. The awarded vendor will start January 2024, and the new centralized credentialing process should begin no later than January 2025. I'll be happy to respond to any questions at the end of the presentation, and we'll now turn it back over to Stacy to talk about the DOJ update.
Thanks. I wish it was DOG, Cynthia. The dog update. I wish it was dogs. Thank you. So this, as some of you may recall, we in October 4th, 2022, the DOJ, the U.S. Department of Justice, found Nevada does not provide children with behavioral health disorders with adequate community-based services. Instead, Nevada is relying on segregated institutional settings like hospitals, residential treatment facilities to serve children with behavioral health needs. And this essentially violates the Federal Americans with Disabilities Act. So in response to that, the state has been in, for the last few months, confidential negotiations with the DOJ on a settlement agreement about what the state needs to do to come into compliance with the ADA. Once this agreement is finalized, the division will host a public meeting about the action items from this agreement for Nevada Medicaid. A lot of the funding, I think we've talked about this during the legislative session, but there will be some funding from the provider tax revenue, which we'll talk about in a little bit. And that will help support some of the activities and new services and supports that are going to come out of this settlement agreement to improve services for children in the community with behavioral health disorders. And the goal is obviously to keep them out of that inpatient and residential treatment setting and to keep them in their homes and their community when possible. Next slide, please. All right, so let's talk about the provider tax. So just a quick update. The good news is as of September 1st, the survey did go out, and as of September 1st, there were enough votes in favor of the private hospital tax with over 67% affirmative vote, which means we can move forward with implementing the new private hospital tax, which will take place on January 1, 2024. So private hospitals will all be receiving an invoice quarterly for their tax amount that's due. And that revenue that we will collect will be used to fund several key pieces that are outlined in statute. The first two are really the supplemental, what we call supplemental payments. So in addition to what we pay hospitals, we'll be supplementing them on a quarterly basis in both the fee-for-service program as well as the managed care program. On the fee-for-service side, that is referred to as an upper payment limit program, a UPL. And then on the managed care side, it's referred to as a state-directed payment program. You can see here that the total supplements federal and the state revenue piece, the total amount amounts annually to about $875.8 million, million dollars, almost $1 billion, in new revenue for hospitals in the state. The first payments that will go out that are supplemental to hospitals in response to the tax will be in March. And then end of every quarter thereafter, those payments will flow. So it's on a quarterly basis. And so the goal is so that way hospitals pay the tax, they know they're going to get the certain amount they're going to get each quarter from paying the tax. It'll be used to support the new payments. The other piece that the revenue funds is the staffing as well as the contract support that we need at the division to implement and operate this program. It also will support, some of the funding can be used to support, like I mentioned earlier, some of the new services and supports for children with behavioral health disorders that we're required to implement under the new DOJ settlement agreement. Next slide, please. All right. I'm going to hand this off. Melinda, do you know who's next? So we're going to talk a little bit about the legislative stuff. Yeah. Okay.
Yes, I'm going to hand it over to Casey to provide this introduction. Thank you.
Thanks, Melinda. Good afternoon, everyone. My name is Casey Angris, and I'm the Division Compliance Chief for the division. And I also serve as one of our legislative liaisons. And so next we'll be walking through some of the updates on the 82nd legislative implementation. Next slide, please. So before we get started, we wanted to go over some different terms and acronyms that'll be used in the next several slides just to make it easier to take in all of this information. And so one term you'll hear quite frequently is a SPA or state plan amendment. So the state plan is basically our contract with CMS or Center for Medicare and Medicaid Services that describes how the state administers its Medicaid and CHIP programs. And so anytime there's a change that needs to be made to our state plan, such as legislation being passed, we're required to submit a state plan amendment or SPA to CMS that outlines the changes along with the revised pages of our state plan. Another term is MSM, or the Medicaid Services Manual, and that sets forth policies for administering our Medicaid and CHIP programs in accordance with the state plan. And the adoption of any new provisions or changes to the MSM is done in accordance with NRS 422.2369. The MMIS, which is the Medicaid Management Information System, is the system that's approved by CMS for Nevada Medicaid to utilize for its claims and prior authorization processing. So when changes are made to the Nevada Medicaid program, there are sometimes system updates that need to be made to the MMIS in order to accommodate those changes. The billing manual and billing guidelines by provider type are procedural documents that are maintained by our fiscal agent, and they provide support and instructions for Medicaid billing and sort of serve in concert with the Medicaid Services Manual. Next, we have the fee schedule, which is a listing of reimbursable services as determined by the division's respective policy teams. The rate analysis and development unit uses the methods and standards outlined in the state plan to determine appropriate reimbursement rates for each service. And then we have federal waivers. And so there's provisions in Medicaid law that allow the federal government to waive certain rules that apply to Medicaid in order to allow states to provide healthcare options that are tailored to groups with particular needs and health conditions. And so these waivers have to be submitted to and approved by CMS as well. And the last one we have is RFP, or request for proposal. And this is part of the vendor procurement process where the state solicits a vendor to perform certain activities that are related to the administration of the Medicaid program. And so with that, I'm going to hand it over to Jamie Evans for the next slide.
Have a great one.
You too. Take care. Keep doing all the things you're doing.
Oh,
Well,
can we make sure to have it?
Yeah. I mute everyone. Thank you.
Thanks, Casey. My name is Jamie Evans. I am the acting chief of managed care, the managed care unit here at Nevada Medicaid. And as most of you know, during the 81st and 82nd legislature, Nevada was approved and received funding to expand managed care from urban, Clark, and Washoe counties to all counties going statewide. Today, managed care currently serves approximately 75 to 78% of Nevada Medicaid's population. If we were to implement today, we would see approximately 75,000 recipients move from fee-for-service to managed care, or about a 10% increase of Medicaid recipients being served by our managed care program. The managed care program, contract, and state plan benefits are not changing with this expansion. The populations that will remain fee-for-service still include children in the Katie Beckett program, children in the welfare system, including foster care and juvenile justice, individuals with disabilities, seniors 65 and over, and people in the home and community-based services waiver programs. This expansion effort coincides with the beginning of the new managed care contracts. Managed care contracts are usually awarded for a 4-year period. The current contract ends December 31st, 2025, with the new contracts being effective January 1, 2026. This will also be the date the statewide managed care will commence. In order to procure a new managed care contract, we need to go through the state purchasing RFP process. DHCFP is currently in the process of gathering public feedback. A request for information was posted in July with responses due October 17th by 4 p.m. You can access the RI5 via the link on this slide. DHCFP is also touring rural hospitals to better understand the healthcare challenges facing rural communities. Visits to the northern rural hospitals have been completed, and the southern rural hospital visits will begin the second week of October. We will continue to gather public feedback through the end of this year, including at least 3 public workshops to share information and answer questions about the expansion. Development of the RFP and contracting will begin in January 2024. DHCFP plans to contract with a procurement acquisition services support vendor to assist with this process. The procurement process will begin January 2025, with contracts awarded in early 2025. Upon award, readiness and stand-up will occur through December 2025, with the new contracts and statewide managed care effective January 1, 2026. The statewide managed care website will continue to be updated as we move through this process. The goal of these efforts is to ensure the division hears from local recipients, providers, and county officials about their local healthcare challenges and environments to inform the state's approach to the expansion. I'll go ahead and put a link to the statewide managed care website in the chat, but it's also linked on this slide as well. Thank you. Now I'll hand it over to Kim Adams.
Good afternoon, I'm Kim Adams. I am the manager over the rate analysis and development unit here at Medicaid. So there were numerous items that were approved during the 2023 legislative session to grant rate increases for providers. So I'll be going over those. First up on the list is Assembly Bill 237, which is effective January 1st of 2024. This one is actually kind of in conjunction with the second to last row on this sheet, the skilled nursing facility rate increase. So between AB 237 and SB 504, there will be a total of a 24.5% rate increase implemented for provider type 19. This rate increase will include the weighted budget neutral per diem that's used to calculate standard bed days, the $495 figure that's added on for vent rates, and then also pediatric level 1 and level 2 services. The division will also be submitting a state plan amendment to amend the way that federal match is collected for the nursing facility provider tax program. The change will allow us to collect a higher federal match for the newly eligible population. Next up is Assembly Bill 277 for rural emergency hospitals, also effective January 1st, 2024. Rural emergency hospitals are a new federal distinction. I believe that just started at the beginning of this year. So the division plans to submit a SPA to increase reimbursement rates for hospitals that convert to a rural emergency hospital. Senate Bill 241, also effective January 1st, 2024. This allows the division to pay cost-based rates for critical access hospitals. So it includes outpatient services for public critical access hospitals and swing bed services as well. Then there is a rate increase scheduled for applied behavior analysis or ABA services effective 7/1 of 23. This one actually stems from Senate Bill 96 of the 2021 legislative session. That bill required that DHCFP pay ABA services at similar rates paid by other states. During our initial research, we found that aligning reimbursement rates with other states would have decreased reimbursement for some codes. However, during the 2023 legislative session, the legislature only approved amending rates when the resulting change resulted in an increase to the rates. So as a result, some of the rates on the fee schedules will not change, but others will increase. The amount change varies by code, anywhere from less than a 1% increase to almost an 80% increase, and the average percent change is about 41%. There is a public hearing for that state plan amendment next week on the 26th. Then let's see, a dental rate increase. This one is also effective January 1st, 2024. This approves a 5% rate increase under provider type 2022. Next up is a rate increase under the frail elderly waiver, residential facilities for groups, also effective January 1st, 2024. This comes from our quadrennial rate review responses from 2021 for this provider type. The rate change varies by code, but the average percent increase is around 50%. I did want to note that for waivers, the effective dates are a little bit different than they are for SPAs. So for state plan amendments, we can make those retroactive to a certain point. There's some rules around that on a federal level. For waivers, the effective date of the rate change can be no earlier than the date that CMS approves the waiver amendment. So if for whatever reason CMS didn't approve that waiver amendment until, let's say, January 3rd, then the effective date for that rate change would be January 3rd. There's also a public workshop for that waiver amendment next week as well on the 26th. Next up, a physician rate increase, also effective January 1st, 2024. This is a 5% rate increase for services under provider type 20, which does include anesthesia services. And then we talked about the skilled nursing facility rate increase when we talked about the first one on the list. And last up on this slide is the parity for advanced practice registered nurses and certified nurse midwives, who are to be paid in parity with physicians effective January 1st, 2024 as well. When we set rates at parity, it will be after that 5% rate increase for physicians is applied, and it also includes the pediatric enhancement that's allowed for some physician services when provided to a recipient under the age of 21. Okay, ready for the next slide. Then we have a rate increase for home health effective January 1st, 2024. This is a 15% rate increase and includes private duty nursing. Next up is the all payers claims database, which I believe April is going to talk about.
Hi, thank you, Kim. I appreciate that. Good afternoon. My name is April Karn, and I'm Chief of Information Services here at Nevada Medicaid. SB 504 allowed the department to pursue the implementation of an all payers claim database. The APCD is a large database that will include medical claims, pharmacy claims, dental claims, and eligibility and provider files collected from private and public payers. Insurers will report data directly to the APCD. The establishment of an APCD allows Nevada to collect data in an effort to improve healthcare transparency by permitting the examination of costs, quality, and utilization. Access to the APCD data will assist the state in assessing the impact of programs, demonstrations, and initiatives, as well as assist with health policy decisions that support healthcare and payment reform initiatives. A public workshop was held on August 30th, and the team is reviewing the feedback provided in that session now. We are currently in the procurement process for a vendor. Now I'd like to go ahead and hand it back over to Kim.
Perfect, thank you. Okay, back to the rate increases. So the next one is a rate increase for the frail elderly waiver assisted living facilities, also effective January 1st, 2024. This one also stems from the quadrennial rate reviews responses from 2021 for this provider type. Again, the rate change varies by code, but the average percent increase is about 98%. Again, we have the same note here on the waiver effective dates that they can be no earlier than the CMS approval dates. There's also same public workshop for this one being held on September 26th, so next week. Next up is a change to pregnancy eligibility. So Senate Bill 504 also allowed the division to expand Medicaid eligibility for pregnant individuals effective January 1st, 2024. And so those individuals can have income levels up to 200% of the federal poverty level. And then last up on this slide is Senate Bill 511, which is a rate increase for personal care services and PCS-like services provided under a few of our waiver provider types. So this change stemmed from a recommendation from the Home Care Employment Standards Board. So the rate for personal care services, is being increased to the equivalent of $25 per hour. That code is usually billed in 15-minute increments, so it would be scaled accordingly. But it also includes a requirement that the minimum wage for direct care staff be no less than $16 per hour. Like I said, this also applies to some of the services under provider type 48, which is the frail elderly waiver, and provider type 58, which is the physically disabled waiver, as these were determined to be similar to personal care services. And then those waiver changes under provider type 48 and 58 are also subject to that CMS approval date rule. And we are holding a public workshop on September 26th for this, as well as we anticipated there might be some questions about the minimum wage requirement and things like that. So please attend if you do have any questions about that. I think that's the end of the rate increases on this slide. So I'll go ahead and hand it off to Sarah Dearborn.
Good afternoon, everyone. My name is Sarah Dearborn, and I am the Behavioral Health Unit Chief, and I'll be providing updates on the behavioral health related bills. So first up is Assembly Bill 137. This requires the division to develop services for individuals with fetal alcohol spectrum disorder. The division is currently researching the health home benefit authorized under Section 1945A of the Support Act and how this can be used for individuals with fetal alcohol spectrum disorder. This will require a state plan amendment, a new Medicaid service manual chapter, as well as Medicaid management information system updates. This bill has an effective date of January 1st, 2024, and we're planning this new change to be heard at the December 26th public hearing. Because this is a new benefit to Nevada, we hope to hold a public workshop tentatively for October to engage the public and stakeholders in this new program. Next up is Assembly Bill 138. This requires the division to reimburse for behavioral health integration services. This will support expanding access to behavioral health by integrating behavioral health into primary care settings. This will require a state plan amendment, possible updates to Medicaid Service Manual Chapter 600, which is physician services, and Medicaid Service Manual Chapter 400, which is mental health and alcohol and substance use services, as well as adding new billing codes to the Medicaid Management Information System. This bill has an effective date of July 1st, 2024, but because this is a new program, we hope to hold a public workshop to engage feedback around April 2024. Because this bill is not effective until next year, it is uncertain how it may be impacted by other bills that were passed this legislative session, and further research is needed to detail specifics. I will hand it over to Yvette.
Hello, good afternoon, everyone. My name is Yvette Cullen, and I am the Chief over Medical and Dental Programs here at Nevada Medicaid. I'd like to present AB 155, and that is a bill that required Nevada Medicaid to include coverage of biomarker testing for the diagnosis, treatment, management, and ongoing monitoring of cancer in certain circumstances. We anticipate going to public hearing October 31st to make this bill have an effective date, this policy as of November 1st of this year. And I will hand it back over to Kim.
Perfect, thank you. All righty, so next up is Assembly Bill 283, which was a rate increase for doula services effective October 1st, 2023. This bill will increase reimbursement rates for all doulas. The delivery code reimbursement will increase from about $150 to $900, and then visits will increase from $50 per visit to $100 per visit with a maximum of 6 visits. Additionally, this bill allows DHCFP to provide enhanced rates for services provided to recipients living in rural areas of the state. So the rates for services provided to recipients in those regions will be set at 110% of the increased doula rate. So $990 for delivery codes and $110 for visits up to 6 visits again. That one is also going to public hearing next week on the 26th. And then last up on this slide is Senate Bill 439, which was Communicable Disease Coverage Bill. This bill makes changes to coverage for reimbursement of services related to communicable diseases. It allows the division to pay physicians' assistants in parity with physicians when providing services to treat, test for, or prevent HIV or hepatitis C. Physicians' assistants will be paid in parity with physicians only when meeting that criteria effective January 1st, 2024. And I believe Kirsten is up next.
Yes, thank you. Good afternoon. My name is Kirsten Klum. I'm the Chief for Long-Term Services and Supports, and we had a couple of bills this session that I'd like to give you an update on. So the first one is Assembly Bill 208. So this actually is creating a brand new waiver for Nevada. So we will have a 4th waiver. It is specific to individuals with dementia and really trying to assist their families, the family caregivers that are providing that care to them in that home and community-based setting. It does have a kind of a later effective date of January in 2025. That's because we have a lot of work to do in terms of developing a new waiver application
integration. We have to develop new policy, make updates to our system. We'll have to develop a brand new billing guide and fee schedule and an enrollment checklist. So we'll be quite busy with that. We will be looking to engage our public partners and stakeholders later this year, probably early next year. And then also in our waiver space, Assembly Bill 259. So what this bill does is essentially has two kind of primary options. So the first is working on a phased out approach of the minimum wage. That really is the lead division for that will be Aging and Disability Services, but that's looking to phase out that sub-minimum wage standards that individuals with intellectual disabilities may receive. And then what Medicaid will be working on with Aging and Disability Services is a brand new service to the ID waiver. And so that is for benefits counseling. So similarly to the first bill, we will have to work on doing an amendment to our existing ID waiver. We'll have to update our policy to add in that new service. We'll have to update our system to add in that new service, as well as make those other change updates for that new service to the ID waiver. So this one also has an effective date of January 2025 to give us some time to work on all of those things. So again, similar process late this year, early next year for seeking stakeholder input. And then SB 45 is for individuals that reside in a skilled nursing facility. So it made an increase to the personal needs allowance. So when an individual is in a nursing facility, they currently receive $35 a month for their personal needs allowance. And this bill really is setting an unprecedented increase to that. So it's very exciting for them. It'll match what the personal needs allowance for individuals that are in a residential facility for a group. So we are working closely with the Division of Welfare and Supportive Services to update our state plan amendment. The effective date of that bill is January 1st of 2024. So next year, we're still trying to work on determining when that public hearing will be. That those spot pages are about 21 years old. So we'll be working closely with CMS to make sure we can get that updated correctly. And then the last two ones for SB 504. So the first input that we would be seeking would be to the rate increases. So that one actually we were able to, for the ID rate increases, we were able to use public health, the Public Health Emergency Appendix K authority to do that rate increase actually effective July 1st. We will be doing a second phase of that rate increase coming in April. So we'll be working closely with Aging and Disability. So the July 1st, we already had to do that public comment period in the end of July, but we will have another public comment period for phase 2 of those rate increases. And then lastly, we would just have our pretty standard waiver slot increases that we have for each of our waivers. And so we are currently in the public comment period for the Furrow Elder and Physically Disabled waiver, FE and PD. And then we are in the process of renewing our ID waiver. So we already included those slot increases for that ID renewal. And so that's why that public comment period already ended. And I will turn it over to Yvette, as I understand it.
Hello again. AB 277 authorizes a rural emergency hospital that meets requirements to receive an endorsement as a crisis stabilization center. As Kim had stated earlier, this increases Medicaid reimbursement for particular services provided by these rural emergency hospitals. We are anticipating going to public hearing at the end of November on the 28th, and we can implement policy effective the 1st of January 2024. SB 117 adds additional providers that can supervise community health workers, also known as CHWs. We anticipate going to public hearing next week on the 26th for policy. For rates, they will take it to public hearing October 31st, and policy will be effective October 1st, and for rates, January 1st of 2024. And Sarah, you are up.
Thank you, Yvette. Senate Bill 119 provides authority for the state to pay the non-federal share of expenses for services in the same amount as in person or by other means for counseling or treatment related to a mental health condition or a substance use disorder, including without limitation when such counseling or treatment is provided through audio-only interaction. This bill will require edits to Medicaid Service Manual Chapter 3400 for telehealth services, as well as Medicaid Management Information System updates. This bill had an effective date of July 1st, 2023, and we anticipate taking the proposed updates to Chapter 3400 to the November 28th, 2023 public hearing. And I'll hand it off to Jamie.
Thanks, Sarah. Senate Bill 146 revises regulations to authorize a certified nurse midwife to perform a physical examination or obtain a medical history before or after a patient is admitted to a hospital for the purpose of giving birth. DHCFP already reimburses certified nurse midwives for these services, therefore no SPA or MSM change is required. Additionally, SB 146 requires a health carrier, including Medicaid managed care organizations, to comply with certain provisions governing network contracting. MCOs are required to remain compliant with the state and federal policies and will be mandated to provide in-network contracting that aligns with the provisions of this bill. A contract amendment is in progress to ensure compliance with an effective date of the effective date of this bill is October 1st, 2023. I'll go ahead and pass it back over to Yvette.
SB 163 requires Nevada Medicaid to cover treatment of additional procedures related to gender dysphoria and gender incongruence. We will anticipate going to public hearing next week on the 26th, and we can make the effective date the beginning of next month, October 1st. And Sarah, back to you.
Thank you, Yvette. Senate Bill 191 requires Medicaid to expand applied behavior analysis services for individuals 21 and younger to 27 and younger. The division is currently considering options to add this benefit in state plan or perhaps pursue a waiver for these services. This bill will also require updates to Medicaid Service Manual Chapter 3700, Applied Behavior Analysis, a Medicaid Management Information System update, and a possible MCO contract amendment. The effective date of this bill is January 1st, 2024, and we anticipate taking this to the December 26th public hearing. I'll turn it back to you, Yvette.
Senate Bill 221 revises provisions related to Nevada Medicaid reimbursement for special clinics that treat children with cancer and rare diseases. We are anticipating going to public hearing for policy on September 26th, and we could implement policy effective October 1st. For rates, it is to be determined when we will be able to go to public hearing. Next bill is Senate Bill 232, which requires Nevada Medicaid to include coverage for postpartum care services up to 12 months now. We anticipate going to public hearing the end of November, and we'll be able to implement policy effective January 1st of 2024. Senate Bill 280 revises provisions governing long-acting removable contraception, also known as LARCs, to be available after birth. And we are going to anticipate going to public hearing the end of October on the 31st for policy. That would make our policy change effective November 1st of 2023. The rate change and carve out would be effective January, and they anticipate going to public hearing to be determined sometime before that. And Sarah, I believe that you are next.
Thank you. Senate Bill 504, as part of the approved Medicaid budget, requires the division to remove neurotherapy and biofeedback services for the treatment of a mental health diagnosis. This will require a state plan amendment, a Medicaid Service Manual Chapter 400, Mental Health and Alcohol and Substance Use Services update, as well as a Medicaid management information system update to remove the codes. These services will be removed effective April 1st, 2024, and we anticipate taking these changes to the March 26th, 2024 public hearing. And I will hand it off to Melinda.
Thanks, Sarah. So the section 1115 waiver referenced in AB 389 requests waiver of the inmate exclusion policy for inmates that meet certain health criteria. The division anticipates to onboard staff devoted to the design, submission, tracking approval, and management of this demonstration waiver in October of this year, and will then contract with a vendor to provide technical assistance, expertise, support, and ad hoc analysis to support the division in these activities beginning this winter. The division will also establish an interagency working group with the Division of Welfare and Supportive Services, or DWSS, and Department of Corrections to ensure successful implementation upon federal approval. Nevada Medicaid will ensure effective collaboration so that other bill-related programs that may be required of our partner agencies do not impact this project negatively, and vice versa. The division aims to have the federal waiver application completed by October 1st, 2024. Public comment period will be open October 15th through December 15th, 2024. As required by federal law, the division will host at least 2 public hearings during the 45-day public comment period. Once scheduled, these public hearings will be publicly noticed, recorded, and posted. The division plans to submit the Section 1115 waiver application to the federal government by January 1st, 2025, with a requested effective date of October 1st, 2025. With that, I'll pass it back to Sarah for this next slide.
Thank you, Melinda. For this next slide, I wanted to provide a snapshot of the work the Behavioral Health Unit will be working towards throughout the end of the year. Many of these projects are already in motion and have been in process for a while. However, we will also be sprinkling in some new projects to include many of the bills that were passed during session that supported Nevadans' access to behavioral health services. All projects will include significant research as well as engagement from the public and stakeholders as we move these accomplishments forward. So you'll see opportunity for public engagement through workshops as well as listening sessions to learn and provide feedback. Near the middle of the slide, you'll see 2 gray arrows. These are 2 new provider types in development to support both the work being done to build out Nevada's crisis system, as well as the evolution of substance use treatment services to complement the 1115 substance use disorder demonstration waiver. At the bottom of the slide, you'll see several purple boxes full of the projects we are moving forward. First, you'll see intensive crisis stabilization services, as well as mobile crisis response delivered by a designated mobile crisis team. The coverage definitions, as well as the reimbursement methodology, are currently under review with CMS. Pending CMS's approval of the state plan amendment, DHCFP will be able to press go on the new crisis provider type and begin reimbursing for some of the critical components of the crisis system. Next, you'll see between October and November, the Behavioral Health Unit is hoping to hold some public workshops to support implementation of a couple items. The first one being Assembly Bill 137, which I mentioned earlier. Also, hosting a public workshop on the development of a bundled daily rate of payment for substance use treatment, residential providers delivering services under the 1115 substance use disorder demonstration waiver. And then also hosting a public workshop that will be focused on new language for behavioral health services delivered through a federally qualified health center. You'll see a couple boxes mentioning the 1115. This is specific to deliverables required as part of the approved 1115 substance use disorder demonstration waiver that allows Medicaid to now reimburse for residential and medically monitored substance use treatment within an institution for mental disease for all ages. Prior to the waiver authority, Medicaid was prohibited from reimbursing for this treatment for individuals ages 22 to 64. You'll see the evaluation design is coming due. This evaluation design is what Nevada's independent evaluator will use to measure the progress of the 1115. Also, you'll see an opportunity for the post-award forum in November. This is similar to a public workshop and will communicate and engage the public on the progress of the 1115 demonstration. I'd also like to highlight the proposed listening session that the unit will be hosting to support Certified Community Behavioral Health Center expansion that was approved within the Medicaid budget this last session. The division has determined to open up enrollment for provider type 17, specialty 188, Certified Community Behavioral Health Center across the state to those that qualify. The division has also determined to roll all CCBHCs under state plan authority rather than have separate functioning cohorts through demonstration and state plan. This listening session will inform interested agencies about the CCBHC program and certification process. The last two boxes are the final two public hearing dates of the year, where we are targeting to present several bills like Senate Bill 119 and Assembly Bill 156 for the November 28th public hearing. For the December 26th public hearing, we intend to present on state plan amendments and Medicaid service manual policy updates related to Senate Bill 191, Assembly Bill 137. We'll prepare for CCBHC expansion. We will work to amend state plan to include a bundled daily rate methodology and coverage language for substance use disorder treatment in a residential setting, which will complement the new substance use treatment provider type that is in development. And finally, we hope to present a couple edits to the Medicaid Service Manual, Chapter 400, to ensure the designated mobile crisis team time and distance standards are in line with national best practices. I understand this slide addresses many different subjects and may take some time to soak in, and I'm happy to answer specific questions at the end or through email, but for now I will hand it over to Dr. Benson.
Thanks, Sarah. Good afternoon. My name is Dr. Keith Benson, the State Dental Officer, and I'm going to go over some dental updates, including bills and an 1115 dental waiver. First is Senate Bill 310, which is effective January 1st, 2024, and it expands the functions of both dental assistants and dental hygienists, as well as allows the dental hygienist to prescribe to patients preventative medications. The Nevada State Dental Board will be producing regulations in all these domains, including licensure and education. We'll be updating our Medicaid policy and systems to allow reimbursement of preventative medications prescribed by specially licensed dental hygienists. This workshop October is from the Nevada State Dental Board, and hopefully that they will come up with some regulation in that domain there, which we can then help follow in our Medicaid policy. Next up is Senate Bill 385, which again is effective January 1st, 2024. And it requires Nevada Medicaid to apply for a waiver or amendment to the state plan to include fillings, crowns, and dentures for adults. We are developing a strategy for implementation to safeguard standards of dental care. This legislation will require a state plan amendment approved by CMS and updates to our Medicaid policy and systems. Next is Assembly Bill 147, again effective January 1st, 2024, and it allows the use of teledentistry in certain instances, and legislation requires that Medicaid's dental benefit administrator, which is Liberty, to maintain and update a quarterly list of licensed teledentistry dentists to hospital emergency rooms around the state to be provided to Medicaid patients at those facilities. This legislation will allow a dentist, dental hygienist, or dental therapist to administer vaccines after completing a special endorsement that's going to be determined by the Nevada State Dental Board. This board is developing specific regulations both around teledentistry and vaccination, and from those regulations, we will help to develop our Nevada Medicaid policy. Next is our 1115 dental waiver, which will expand dental services to Medicaid adults with diabetes who are patients of record at participating federally qualified health centers and tribal health clinics. We are still awaiting official approval by CMS. Many startup activities are already in progress, and I estimate with CMS approval, hopefully in early fall, and approval of our implementation plan, waiver services could start as early as April of 2024. Now I will hand it off to pharmacy and Mr. David Olson.
Thank you, Dr. Benson. I'm David Olson, the Chief of Pharmacy Services and Durable Medical Equipment Unit. Starting with Assembly Bill 156. As Sarah Dearborn was outlining, this is a bill to increase the access to medical assisted treatment, opioid use disorder drugs. It would allow pharmacists to prescribing authority. As part of this project, my unit would be updating the drugs in the system that pharmacists or provider type 91 would be able to prescribe, and then we would test the claims. A public hearing related to this project, as mentioned, will occur November 28th of this year. For the next bill, as Dr. Benson outlined, it's to allow for limited prescribing authority for dental hygienists. In partnership with him, we'll be working to make any needed system changes for dental hygienists to prescribe, and testing claims as part of that as well. And as the many times mentioned bill, budget bill SB 504, this will be allowing for the coverage of wearable cardiovascular defibrillators. This is part of the Durable Medical Equipment Unit, and it will involve system testing. The effective date is anticipated to be at the beginning of the year, and we anticipate that at any point we'll be able to open those codes and rates will be updated. No state plan nor policy changes will be needed to implement it. And then we also wanted to specifically highlight Chapter 1300, which is the policy for durable medical equipment, prosthetics, and other supplies. The policy updates are anticipated to be coming later this year. We would like to share more information and outline planned edits in an upcoming public workshop that will hopefully occur next month or shortly thereafter. We will focus on increasing communication with vendors as part of those edits, and we will be taking significant time to revise policy. The unit also monitors several other bills during session that you don't see listed here. It's the case with those bills that the policy or process was already in place. However, we will be adding supporting NRS citations to policy once those are available, and that will be part of Chapter 1200. I would now like to turn the time back over to Melinda. Thank you.
Great, thank you, David. All right, and with this slide, so you heard a lot of presenters mention public hearing, and so we wanted to provide the dates of the next public hearings that are scheduled in 2023, as well as some helpful links for you all. These links here go to our public notices webpage. So that's the webpage where hopefully you got the notification for this meeting and the agenda. And I also want to highlight that the presentation for this meeting is also posted at that same location. And then we do have links to both the 2023 and 2024 public hearing schedule. So you can see what those dates are to engage with the division on these different policy changes. And I also want to make the reference that we invite comment, before the public hearings, of course, so that we can work through any significant changes that might be needed. And usually we do that through the public workshop process. And our public workshops are also posted on our public notices webpage whenever those are scheduled. And we usually do send those out through our listserv as well. So we just invite, that two-way communication with you all. And then the last link is about our notifications and news. So there are several listservs that you all could sign up for that are listed on that webpage, including the statewide managed care listserv that Jamie had spoke about. And then I also included our community and provider engagement unit email here for you all. If there's something that we can be doing different, really appreciate if you could, drop us a line and let us know what you think. And with that, I'm going to turn it over to Stacy again to have any closing comments, and make sure to reference the survey link at the end of this presentation. Thanks.
Thanks, Melinda, and thank you all. I know that was over an hour, so really appreciate everyone's, or almost an hour, everyone's attention. We wanted to turn it over to you all. I know there have been a couple questions already in the chat, which is great, but I just want to make sure we open it up for questions, and really just want to say thank you. And obviously we have a survey. Melinda, if you want to go to the next slide, we'll put this link also in the chat, and just to get feedback on whether or not this was helpful. We're trying our best to get more information out in a more streamlined way. So just curious what you think, and if there are things that we could do differently next time. But thank you. I like emojis, so thank you. So if you guys want to start with questions, what I'll do is I'll read a couple here in the chat here. So I don't know, Janelle, the therapy codes on the rate increase, which rate increase were you referring to again? Janelle, are you still on? Okay, maybe she had to jump off. Janelle, can you hear us? I don't think we can hear you. Let me see. All right, well, okay, just so you know, I don't know, Kim, if you had initial thoughts about her question. I know she asked it whenever you were, the physician increases. Kim, did you want to answer that one? I don't think physical therapy counts in the physician bucket, but I'll let you discuss that.
So it would depend on what provider type you're enrolled under. Provider type 34 therapy does not have any rate increases scheduled. Provider type 20, it's the entire fee schedule is increasing by 5%.
And can you tell her what 20 and 34 are? Just sorry, just in
34.
Case, yeah. Okay.
34 is therapy, 20 is physician.
And then Janelle also had a question about the pelvic floor therapy. So whatever is current, my understanding, obviously the team is still working on this benefit, and we'll be consulting with Dr. Clemens on our team. But the way it was fiscal noted is that we assumed a similar benefit set. It was just extended. So today we cover postpartum care for 60 days. So we're extending that for 12 months. So I think, we are assuming, and we were funded accordingly, that we would continue whatever we currently cover today. And based on my quick perusal, we'll have to confirm later that pelvic floor therapy is not currently a covered postpartum care benefit necessarily. So, but obviously when you come to the public workshop, that's something to raise and give us feedback on. And if you want to have a follow-up conversation with our team and Dr. Clemens, I definitely want to say, reach out to us, send Melinda an email through that community provider email address, and we can follow up on that. And then Mike, I saw that you had the wearable cardio defibrillator life vest question. I saw on that slide when you put this question up. Did you get your answer?
Yes, I think I have the answer. I just wanted to make sure that a lot of information was provided when the fiscal note was created, cost savings. Yeah. I couldn't really tell from the discussion whether you need any additional input or information, or it's just process.
Or just it's process. So thank you. Yep, all good there. The other question we have is, will there be increases to rates for crisis stabilization centers? So as I mentioned earlier, we are funded what we are funded. So crisis stabilization services did not get an additional rate increase during session. We understand some concerns with the initial rate. We are able to get it to $600. I think it was a little bit under that. And my understanding, and Sarah, please chime in a second, DBPH is going to supplement that funding on their end until we're able to get additional revenue through the provider tax revenue to help increase rates. Sarah, did you want to correct me if I jumbled that?
No, and I just also wanted to enforce that this is still pending CMS approval, so this is not a reimbursable service currently. But of course, we're working hard with CMS to get that approved. So once that is, then crisis stabilization services that could occur in a crisis stabilization center or a community facility based could be reimbursable.
Thanks, Sarah. All right. How will you be reevaluating Medicaid eligibility for children and families who have been disenrolled by ex parte? Sandy or Vanessa, did you want to chime in on that one? You want me to repeat the question?
I'm trying to find the question.
Sorry.
Do you want
Sorry,
to take it, Vanessa, or do you want?
Yeah. So they will go through ex parte. Right now, the ex parte is being corrected. So those who were disenrolled will they'll go through ex parte again. And I believe it's either going to be at 12 or 6 months, depending on if they were reinstated or if we push the renewal date to 6 months. So the difference between ex parte today and how it's going to be fixed is right now we're doing it at a household level, and when it's corrected, it will be done at an individual level.
Thanks, Vanessa. And just for folks' clarification, because I know it is confusing, in Nevada Medicaid, we do everything but eligibility. So our front door, essentially, how you get into the program, is held under the Division of Welfare and Supportive Services. And so Vanessa and Sandy are working a lot together with them on this issue because we are the Medicaid program, essentially. But when it comes to some of these changes, if you have questions for a recipient, it is best to take it to DWIS. If you're a provider and you want to know what does it mean for payments, retroactively, all those things, please come to us on those things. We can help you there. But we're doing our best to get, coordinate with them on messaging because we know it can be confusing. All right. Thank you, Vanessa and Sandy. All right. So the next question, and if I'm skipping some, I'm sorry. My eyesight is getting worse. There was an attempt to remove biofeedback services last year, and it was rescinded due to a conflict with other federal programming. What has changed now that is able to be scheduled to be removed again? So we are removing during session. We had a budget item in the governor's budget to remove biofeedback services, therapy services. And so, Sarah, I'm not sure on the timeline, but I think it's already been removed. Is that correct?
Not quite yet. So just to explain to Brandon's question, you're correct. It was attempted to be removed last session, but because the state was receiving home and community-based ARPA funding, CMS was not going to allow home and community-based services, any home and community-based services to be removed, which is why you see that later date of April 1st of 2024. That's when that ARPA period ends for us, and that's when we will be able to remove those services. And that, just to clarify, it's neurotherapy and biofeedback for the treatment of a mental health diagnosis only.
Great, thank you, Sarah. And then we have another question from Leah Case. Will there be DER SSSB updates related to SB 167? David, did you want to take this one?
Certainly.
Thank you.
So during session, we submitted a fiscal note. It's indicated on the fiscal note and is the case today for drugs treating a psychiatric condition. We do not have step therapy, so we will not need to make any system updates or changes for those drugs as the current status quo is.
Leah, I see your hand up. Did you want to chime in?
Yeah, I'd love to ask a follow-up question if you don't mind,
No.
David. Is that the case with the new definition of step therapy in the bill?
Yes, so step therapy, that would still be the case. The step therapy is under the DIR board, if there was to be any step therapy on drugs. And so for these specific drugs, there is not step therapy. And so that would include the current definition in the bill.
Thank you.
Thanks, David. Thanks, Leah. Let's see. Under the, and so from Char Frost, under the MCO expansion, can you clarify what populations are included under the term individuals with disabilities? Yes, so any folks that are covered as what we consider disabled SSI and Medicaid, or who qualify for our waivers for services in the home. Could also be individuals with intellectual disabilities, physical disabilities, elderly waiver. And Kirsten, there's one more I'm forgetting.
Yeah, you had a physically disabled and or for elderly.
Okay,
as well as IDD.
All right. Okay. Thank you. All right. Sarah, you're asking about the in lieu of services. So we are hoping for January 1 approval. It's with CMS right now. We are in the process of going back and forth for in lieu of coverage for housing supports. And we're just in that process with CMS right now of answering what it looks like. And then once we're in a good place with them, we'll be able to amend our contracts and move forward, hopefully with a start date of January 1, 2024. And then we'll definitely have a meeting later on closer to then about what we end up getting approved. So you guys have a sense of what's coming. So I don't want you to think that it's just going to happen and there's no story there. We're just in the middle of still answering all of their many questions. Angela, do you mind popping on, Angela Magnums, and explaining your question? I'm sorry, don't think I understood it as well.
Yeah, no problem. Can you hear me? It's
Yes.
probably more of a question for Sarah. I know I've worked with Sarah a lot. Hi, Sarah. So we've been anticipating the launch of the 1115 waiver. We've been in discussions with the MCOs. The MCOs are claiming not to know anything, not having a start date. They won't let me credential any of my residential locations. So we were curious with that timeline, and thank you for making that. It's very helpful. If the public hearing about the bundled rate, if that isn't till the end of December, are we thinking this isn't going to start until January?
Thank you, Angela, for the question. I appreciate it. So the goal is to have a public workshop on the bundled rate first, to just engage everybody in what that bundled rate might look like. So there will be opportunity to talk about it then as well. And then you're right, the public hearing hopefully set for December. And then we have to do our work with CMS after that. So we do anticipate this probably being reimbursable some point mid next year. So luckily we've got DPBH's support on this as well, and the substance abuse block grant. So luckily we've been kind of working together on that so that we can, once we're able to push go, it's guys are sustainable. You're able to survive.
Thank you. Best news I've heard all day. Thank you so much. Excellent meeting today. Thank you.
Thank you. All right. So as you mentioned, the pediatric enhancement rate for physicians reimbursement, will that be added to any other providers that treat the pediatric population? Kim?
That pediatric enhancement as of right now is only applied to provider type 20 physicians. And so when we move APRNs and CNMs to achieve parity with physicians, they will also qualify, but it will only be those three types of providers who get that pediatric enhancement.
Great. All right. Are there any other questions from the group? Just you can raise your hand too. You don't have to put them in chat. I think I got through most of the ones in chat.
So I think we might have missed one, Stacy, on the
Thanks.
strategies for minimizing procedural disenrollments.
Oh, yes. I'll let you take that, Sandy.
Okay. So we have taken advantage of every waiver that CMS has offered to help us with increasing our ex parte percentages. And we do continuously look at what we can do to tweak the system to let more people through the ex parte process. But I think the biggest barrier is really being able to get a hold of the members and the members not returning their paperwork. So To the extent that you can help be an outreach partner for us, that would be really beneficial. You know, we're texting members, we're doing everything we possibly can to have people give us their current contact information. So what we think is happening is that people have other coverage and they just aren't returning the paperwork because they don't think they need to. So that's we believe that's probably a large part of it.
Thanks, Sandy. Any other questions from folks before we let you guys go?
Hey, Stacy, this is Cadence with Washoe County.
Hi.
Just following on with that, do you guys have a PIO that we might be able to connect our local government PIOs with to help push that messaging out?
Yes.
Because I think we may be able, through our channels, to help connect to folks. So I would welcome getting that information at the local government level so we can help with that.
That would be great. So Kai Plaskin, he's on this call. So Kai, do you mind following up with Candace after this call?
And then we
Yeah,
also
Kai, Kai,
sorry.
you know Bethany. If you want, do you know Bethany Drysdale, our PIO? You could reach out to her as well.
Yes, I do.
I will give her a heads up.
Thank you.
Vanessa also put a link to our member outreach page that has all sorts of tools, posters, all sorts of materials you could leverage as well.
Perfect. I will get that to our comms team. Thanks.
Any other questions or thoughts on coordinating together or any ideas on stakeholders? I mean, hopefully this was helpful. We are thinking about doing this again, maybe at the end of the year, beginning of next, just to check in where we are on, because there are a couple bills, as you saw, implementations January 1, and things happen with CMS, so we might have some changes. So we want to make sure we're looping you guys back in at that point. Oh, Brandon, you just put something in the chat. I'm worried about removing a mental health service here in Nevada where we've already had issues. Are you talking about biofeedback? Brandon?
Yes, I am. I just
So
wanted
this
to
is a
know.
legislature, it's a legislative decision. It was the governor's budget. So it was passed. So if you want it back in, you'll have to go next session and bring a case for why it should be added back in.
Okay, thank you.
Mm-hmm. Any other questions, concerns? I'm gonna give it one more minute, one awkward silence moment. Okay, well, thank you all for joining us today. We will post this online and hopefully we'll, do this again in a couple months. Thanks all. Have a good evening.